Okay, now we're going to move into our next module here, talking about clinical versus cultural competence, what matters. Please welcome to the stage Sally Satel, lecturer at Yale University School of Medicine and the W.H. Brady Fellow at the American Enterprise Institute. She's also author of PCMD, How Political Correctness is Corrupting Medicine. And coming out also, I'm going to say something really cool about you. A former nationally ranked hammer thrower, Glenda Wrenn is assistant professor of psychiatry and behavioral science at the Morehouse School of Medicine, director of behavioral health at the Satel Health Leadership Institute. It's great to be with both of you. And I know that you, your special thing is you like autocross racing, which you're going to have to give me a lot more time explaining what that is, but not now during these 15 minutes. But Sally, let me just start with you for a minute. You have written some provocative things saying that you're a race profiling doctor. Can you share with us what you mean, what the core of that means? Actually, that particular article had to do with the biology of response to certain medications. And that's really very much a subset of what we're talking about today. But nonetheless, it is interesting to me in the sense that a lot of this is talked about culture, race, political correctness, how to get right, but you basically took it down to a level and said to ignore certain, whether people are walking in and how they metabolize certain medications is something that you were noticing. So I think it was a provocative piece. It was 10 years ago, but a New York Times article. So start there. Well, it's still relevant. And what I should clarify very quickly is people always think, ooh, race and health, and that makes them nervous. But just think population genetics. That tends to make people feel a lot better, which is to say that groups of people that have a common ancestry from thousands of years ago tend to have certain gene frequencies. It doesn't mean that all black people have these kind of genetic patterns, and white people do, and Asian people do. That's way too simplistic. It's not like that at all. Just that probabilistically there is an increase in certain kinds of genetic variants, and that can affect how medications, psychiatric medications, and particularly actually cardiovascular medications make a difference. So the article was just reminding people that that is relevant to health. For what it's worth, in the kinds of situations we're talking about now, that's actually quite minor. And it really is the social and psychological dimensions that make some of the biggest differences. So let's get to that. And I want to come to you, Glenda. Some of the data, Linda Rosenberg wrote a piece. It was very horrific in looking at some of what the outcomes are. Their African-American babies are nearly 5 times more likely to die before reaching their first birthday than white babies. Suicide attempts for Hispanic girls in grades 9 to 12 are 70% higher than for white girls in the same age group. Lesbian, gay, and bisexual adults are about 5 times more likely than heterosexual men and women to have a mental illness in their lifetime, and so on. And so we started with the question of the biological side, but now we're looking at these other variances in the way different communities in our society are experiencing their health journeys. What has your research shown you?
Well, I think it's important to start off by understanding that race is a social construct. So it's really, I think, problematic to conflate a discussion about genetics and biology when you see categories of people that are racially defined, which there would be no connection expected. And I think the data on infant mortality is pretty startling, because how can you argue with the right of someone who is young to have an opportunity to be born in a safe, healthy environment? One of the things that when we look at the differences in help-seeking and treatment-seeking rates among African-American populations is that the answers really lie in the communities. And when you do work with the community, it's impossible to get away from the social factors that are the determinants of health, because they live and breathe it every day. And as healthcare providers, we often live within a system that's convenient for us, but not necessarily convenient for certain populations. So the work that we do really aims to try to improve our systems of care to be more effective for communities that are not being actively engaged in them in the way, they're not using it the right way, is the way that you could blame a population.
Have you had any success?
Well, yes, I think some folks from Grady Hospital might be here in the audience today. We've had a tremendous amount of success working with Grady, which is one of the nation's largest public hospitals, and their leadership decided that they were going to take on this issue for their population, primarily African American population. And we looked at our system of care in terms of crisis response. And if you look at it out of context, it looked like they were all working hard, doing a great job. But when you look upstream to the emergency care system, to the EMS system, we found that it just wasn't working the way it should. And the conversations before I got there had to do with frequent flyers and people that were overutilizing the system. It didn't really lead to any solutions. But when we changed our system, we redesigned it so that we brought the resources, the behavioral health resources, upstream. And we found that you didn't have to wait for 100 hours to see a psychiatrist to get a prescription. We could change our system, and I think that's really the challenge for all of us.
Sally, when you sort of take a look at this larger factor of clusters, what do you think we're getting right? What do you think we're getting wrong?
Well, I think what the kind of thing Glenda was just talking about is really the way to go. It's really a bottom-up approach. I'm someone who prefers to think more in terms of making everyone as healthy as they can be, rather than focusing on specific groups. But what you do focus on is the group that's underserved. And it takes too long to get an appointment, no matter what their race is. That's something you work on. One of the biggest problems I find, especially in psychiatry, but also in medicine as well, is doctors don't get enough time to spend with their patient. That's huge. And again, that transcends race. And the other is they don't get to see the same doctor time after time, or the same therapist, or the same clinician, so the continuity is broken up. And that's a big problem. Also, you want to, ideally, it's nice to recruit some of the workers at your health clinic from the people in the community, so people feel at home, and keep open office hours that are much later at night, so people who work can come at night, that kind of thing. And that, again, sort of transcends race, but it'll actually help the most people who have hourly wages, hourly jobs where they can get away in the middle of the day, frankly, like most of us probably can. And, so you address it in those, structural ways, but don't get too fixated, and I don't hear you saying this, but don't get too fixated on the, on the race part, on the group part.
Are there places where you've seen communities in this country, in some of those places where people are living tougher lives, not necessarily, people who can't get away from jobs, who are juggling and scrambling and really trying to go every which way to make ends meet, and life stacked against them. And when you look at the health circumstances in those communities, are there any models that you've seen of something developing that has changed the game? Is technology helping? How do you see the future? Because I think the way you framed it is very interesting. But again, come back to the question is, what moves the needle?
High-tech stuff, some of it helps, certainly with, records being coordinated helps, and cell phones, some places use cell phones to make it easier to be reminded of things, to take their medications, or to keep their appointments. But a lot of it's pretty low-tech, like more public health clinics. And again, late hours, things like that.
Glenda?
Well, since this is about an uncomfortable conversation, I think it's important to recognize that a lot of our systems really are not doing a good job of meeting the needs of the communities that they're served. And especially the ones that are placed in communities that are underserved. And I don't think we're capable to have a conversation in this country without acknowledging the history of race, and that there are lasting effects to this day. And in the southeastern United States, I know you know this, that over half of the African American population is concentrated in the southeastern states like Georgia, where I live. So I think particularly, maybe you can ignore it if you're in other areas, but for that particular reason, I think we have to look at our systems of care to see maybe they're the ones that need to be changed to try to rectify these long-lasting impacts of clearly racially based policies.
Right, but that's where you're going to do it. It's in those places. So I agree. I agree.
Tonight in Washington, I'm missing a dinner with a colleague of mine, Ta-Nehisi Coates. Ta-Nehisi won the National Book Award, thank you, for called Between the World and Me, where he really does look at this broad frame of our society and says, you know, a lot of what we have in our country today has been built on the backs of those who've been discriminated against in deep and profound ways. And so I wanted to acknowledge that. But given the fact that we are in a situation now, when you look at Ferguson, you look at the case of Sarah Bland, you look at a lot of the just horrific stories out there, do you have any hope with you and Dr. Satcher and the work you're doing? Is it just always an uphill climb, or do you beginning to see things level out now? Is the level of discussion changing what's happening in, you know, the medical profession?
Yeah. Well, I'm very optimistic, so I think I kind of came with hope.
That just,
it
I
doesn't
thrive
hurt
in
working for
darkness
Dr.
and cynicism,
Satcher, though.
so be a little cynical for me.
Okay,
Yeah.
well, but I am optimistic.
Yeah.
I mean, in our division, we have
But
a parent.
are you naively optimistic, or are you calculatingly optimistic?
I'm calculatingly optimistic.
Okay, good.
Yeah. Well, because I work with the community. So
Yeah.
when you work with underserved populations and you give them a little bit of support, it's incredible what they're capable of doing. We work with our parents, a simple 10-week parenting program that's delivered in a peer format. And, you know, we're going to help them do positive discipline, all the standard things. But what we found is unexpected things were people started nonprofit organizations. People were testifying to the state legislature about issues that were concerning their communities that were chronically underserved. And I think that as healthcare professionals in general, but behavioral health professionals in particular, those of you that care about communities, I think you have to grow from a place of passion. But that's what health equity is about. If you're matching resources to need, when you have these chronically underserved populations that you're able to work with and do a few things with, they really can do a lot with a little, because if you're making less than $10,000 a year, you already know how to do a lot with a little. Excellent.
Sally, let me ask you this question, you know, in the behavioral field, and I'm interested in the question of health literacy generally. You know, I find such great disparities in what people know about what, you know, the mutual responsibility is between someone's own health and those they're seeking care from within a healthcare system. But I'm also interested in the literacy of the healthcare profession. And you're in this, you lecture at Yale, you've been this, but I'd love to get a sense, you know, beyond the broad issues of race, but just what do you do to up the literacy out there? People here in this room are already taking big steps broadly, but we're talking about 320 million people. What can you do to raise the sense of literacy and people's sense of, you know, charting their own course?
Well, you know, this conversation has taken, to me, kind of an unexpected course, because when I think of cultural competence, which was the general overriding framework for this discussion, I think of doctor-patient relationship. I don't think so much of community, frankly, although doctors and their patients, enough doctors and patients equal a community.
Should patients trust their doctors, I guess, is what I'm asking.
Well, doctor-patient, right. Right, communication.
Part of it is a
that
question
is trust, for sure.
Mm-hmm.
Definitely. And, you know, that gets me back to, in a way, well, what is cultural competence? I mean, it's the idea of having a productive engagement with a patient with an eye towards at least awareness that there are going to be some things that are culturally related that one should keep in mind. But that's really the key, is that one should have the humility, the awareness that there's that dimension. You're not going to know it all. Obviously, if you work with an indigenous population, you'll learn more about home folk remedies. You'll learn more, of course, their language issues. You'll learn more about general attitudes towards physicians and disease and family relations. You learn that by being immersed in the population. That's organic, and that's why I would say my soundbite is cultural competence is clinical competence. It's true, it's not always manifest as well as one would hope, but that means that there's a problem. And a lot of it's up to medical schools. We were just talking, we both worked at a VA, and I am embarrassed now that I never even knew what the rankings were in terms of sergeant versus colonel versus, you know, this kind of thing.
Right.
That would be a nice thing to know. I worked with guys post-Vietnam era. It would be nice to know where the major battles were. Those things would be good to know. That you can learn. A lot of the other stuff,
Right.
you learn from the patient. You explore with them, you're empathic, you care about their values and preferences and needs. That's human universal.
We're right at the end, and Glenda, I want to give you the final. Well, thank you, Sally. I think the question about cultural competence and why I ask about that relationship to the doctor and literacy is that sometimes these questions, in the most wonderful form, they take the frame you have. In the most nefarious form, those cultural awarenesses can become deep and dark biases and prejudices that distance people from fair and egalitarian care, right? So I'm interested in whether or not our healthcare system today and how it's evolving is leading to more and more enlightened outcomes, like Sally said, and less to the case where that patient going in has to distrust the doctor because of fear of biases built into the system or a neglect built into the system. Glenda, you get the last word.
Right. I mean, patients already distrust the system. I mean, that's just reality. So that's maybe where my optimism meets reality, in the sense recognizing that people do come with their own feelings because of their personal experience of bias, their own lived experience. And I don't think that our system is going to just automatically evolve to be able to treat people in a culturally centered way. Some of the things, such as the culturally and linguistically appropriate services policy that's set at the federal level, is putting it into words, but we need to kind of think about, I think for a long time we assumed that our systems were doing a good job and that doctors were doing everything that needed to be done and they didn't need any help, and
right.
The patients were the ones always clamoring, saying, it's not good enough, you don't get it. And so the things that we've developed is an attempt to try to rectify that, and I think that we have to just take responsibility and not be Pollyannish to think that it is where it needs to be. There's a lot of places where it still isn't.
Thank you. Are you still practicing throwing hammers?
Only when I'm angry.
Okay, give it up for Sally Satel and Glenda Wrenn. Thank you very much. Thank you so much. Thank you.
Great job.
Thank you. Okay.